My name is Alexa Eggleston. Some of you know, and I've met you and been with you in other sessions, but want to reintroduce myself. I am the Substance Abuse and Addiction Project Director for the Council of State Governments Justice Center. So spent a lot of time working with the National Reentry Resource Center along with my colleague Katie Guerra. Our focus is specifically on behavioral health disorders. So for those of you that have questions, needs, vague concerns or needs around substance use, co-occurring mental health disorders, Katie and I are sort of your main points of contact. You can get our information afterwards as well as on the website. Please know that we are here and resources to you on those issues. Also our job to sort of connect you to some of the consultants that we work with that focus specifically on working with justice-involved youth. So I want to start with asking, sort of, is everyone here a juvenile-focused grantee, mentoring grantees? Any in the room? Okay, great. Demonstration grantees? Are there any of the juvenile co-occurring grantees? I know some of you. Okay, great. So for those of you that don't know, I want to point out in particular, since we're here to talk about sort of behavioral health and justice-involved youth, there is a funding stream as part of Second Chance Act that specifically funds treatment for justice-involved youth with co-occurring mental health and substance use disorders. And a couple of those grantees are in the room. So for those of you that may have programs that have a strong treatment focus and may be looking at finding funding streams, just want you to be aware that that is a funding stream that is available. So my role today is really just to introduce you to our expert panel that we have for you. Three sort of practitioners, researchers have been doing work in this field for a very long time. I'm just going to briefly give you sort of their name, their bio, and then they're just going to sort of informally tell you a little bit more about sort of the work that they do. So first we are going to hear from Dr. Lisa Reiter-Lavery, who is the clinical director and vice president for MST services. I know some of you may be very familiar with multi-systemic therapy, some of you may be using it. She's going to talk a little bit about that, but sort of more broadly evidence-based practice and what we know is really important in terms of working with justice-involved youth. Then we are going to hear from Susan Sytek, who is the director of the Division of Prevention and Behavioral Health Services for the Delaware Children's Department. She's going to talk a little bit more in terms of a state focus and sort of what Delaware has been doing in particular around mental health services for justice-involved youth. And then we're going to hear from Robert Johnson, who is with the Center for Substance Abuse Treatment, the Center for the Substance Abuse and Mental Health Services Administration, and he's going to talk a little bit more about co-occurring and substance use disorder and justice-involved youth. So with that, I'll turn it over to Lisa.
Just a little bit on my background. I worked as an undergrad and then after I graduated before grad school for a psychologist researcher at Duke, doing research on aggression in kids. And it ended up working for him 6 or 7 years. And after grad school internship and my pseudo-doc year, I call it, before I had my PhD, again worked with him on research projects related to aggressive youth and said, I'm done, I don't want to be involved with aggressive youth anymore. Didn't take long before I circled back around and came back to MST, first as a supervisor of a team in Durham, North Carolina, and then went to work for the agency that is the disseminator for this evidence-based, structured, formal treatment model. And what I understand from Alexa is that some of you are using formal, structured treatment models, curriculums, some of you aren't. So what I'm going to speak to as the first speaker here is what the evidence tells us that may help you to think about elements to incorporate into your programs. What I'm going to speak to are foundations for evidence-based practices with delinquent youth. Bottom line, the thing that is the foundation for everything else, right? For everything we do in programs and interventions with youth is a continuous focus on obtaining positive outcomes for the youth and their families. If it weren't for that focus, none of us would be doing the work that we're doing, but it's easy to lose sight that this is our bottom line. Every single thing we do is about obtaining these positive outcomes. As my boss likes to say, every decision is a clinical decision. Whether we're going to fund this project or make this decision, even if it has to do with technology, website. It's all a clinical decision because it's all about, will it support us in getting the best positive outcomes for youth and families. There are quite a number of evidence-based treatments out there now for delinquent youth that have achieved some pretty impressive successes compared to, if you all have been in the field for a long time, you may remember the days 20, 25 years ago when the conclusion was we can't really do anything to help delinquent youth. Well, now we know we can. How can we help them be more successful? Evidence-based treatments have been successful because they're developed from and focus on known risk and protective factors within ecological conceptual frameworks. The individual, family, peers, that's a pretty big one, school and community. All of those elements of the youth's ecology are critical. As we heard in the opening plenary this morning, interventions that focus on the criminogenic factors can make a difference. And I'll go through in some more detail the research that points us to these different elements of the youth's ecology that we know are associated and drive their delinquent behavior. Evidence-based treatments have been successful also because they deliver comprehensive yet individualized services. Again, we heard this morning about how important it is to tailor services to the youth, to the family, to their community, to their culture. And then evidence-based services also have a commitment to rigorous evaluation. They integrate behavioral interventions. Again, thinking back to what we heard this morning in the plenary, with youth, we're going to be much more behaviorally focused as opposed to cognitively focused as we are with adults. Why is that? How many of you have done one-on-one or group treatment with delinquent youth? Oh, a couple? How much fun was it?
It's a lot of fun, actually.
Really? Okay, the guy behind you shook his head. What was your experience with it?
My experience?
Yeah.
It's a real challenge to keep their attention and focus for any length of time.
Somebody over there raised your hand. Did you do? Yes? What was your experience like with it?
Can't talk to them like adults.
Yeah.
You have to do stuff, keep it concrete, keep it moving,
Yeah.
flow with topic change,
It's very different.
different rules of engagement.
Different rules of engagement. In the work I did early on, I did a lot of groups for antisocial kids, and I would say I spent a lot of that time banging my head against a wall. If you're trying to engage kids in cognitive kinds of interventions, that's just not where a lot of antisocial adolescent kids are. It's very hard to engage them that way. So we're going to be focusing behaviorally more than cognitively with the kids. With the parents, different matter, and I'll talk about that in a little bit. Evidence-based treatments have also achieved their success through strong treatment specification, clinical texts and treatment manuals, curriculums, as we heard about this morning, with a continuous emphasis on quality assurance and quality improvement systems. What are the implications for your projects then? Target factors in the youth ecology associated with delinquent behavior as per the research. And we'll go through what the research points to as the relevant factors in just a moment. Pay strong attention to relationships with community stakeholders because you're trying to impact all of these ecologies that the youth is living in, the family is living in. And if everyone's on a different page, it's pretty hard to be heading in the same direction. Finally, build in strong quality assurance and quality improvement mechanisms, ongoing evaluation, ongoing improvement processes into your projects, your programs. So I'm going to dig into each of those in more detail now. Any initial thoughts or questions thus far? Then starting with the theoretical underpinnings of delinquency research and evidence-based programs. They tend to be based on the social ecological theory of Yuri Bronfenbrenner. Isn't it a great name? It's not easy to say. 5 times real fast. Bronfenbrenner. In this theory, we hear about children and adolescents live in a social ecology of interconnected systems that impact their behaviors in direct and indirect ways, and that they act in both directions, reciprocal and bidirectional. And I love this visual. I think it captures very well how the youth is nested in these various ecologies. One of the most compelling elements of this schematic for me is look how far out here a provider agency is. Sibling, caregiver, siblings, extended family, etc. All of these systems are closer to and have a greater impact on the youth. How does that impact how you think about the interventions you would deliver with the youth? Any thoughts? Yes?
We want to incorporate interventions that work with the caregiver and families that directly impact the environment.
Exactly. So the interventions are going to be focusing on all of these different systems that the youth is nested in, because they have the much more direct impact on the youth than we can have as providers from here all the way to there. Exactly. That's probably the single most important implication of this model. The research takes us to the same place. We have a very rich body of research in this area of juvenile delinquency. And what we've learned across more than 50 years of research is that delinquent behavior in youth has 2 direct, powerful influences. Prior delinquent behavior predicts future delinquent behavior, but that's just a reality we know to deal with. We're not going to be able to address the prior delinquent behavior. The single biggest direct factor that we can do something about is association with delinquent peers. And that is the strongest direct predictor of delinquent behavior. There are a number of family variables and school variables and the neighborhood community context that also influence delinquent behavior, but they do so, at least statistically, through their influence on delinquent peers. I'm sorry, the family and school do so through their influence on delinquent peers. Make sense? So when we look at the specific factors through each of the ecologies that the research points us to as influencing delinquent behaviors, at the family level, we have poor supervision, inconsistent or lax discipline, poor relationships between the youth, caregivers, and siblings, parental substance abuse, and mental health problems. Probably all quite familiar to you all as the kinds of problems many of the families present for the youth that you work with. Peer level, association with drug using, I forgot to say this clearly. This research applies to delinquency and drug use. The causal models for drug use, really bottom line is drug use is another example of an antisocial behavior, like stealing, truancy, assault, same sets of causal factors, same interventions would follow from this causal model. So when I talk about delinquency, I'm including drug use as one type of delinquent behavior. Peer level, the research points us to association with drug using and or delinquent peers, poor relationships with peers and or peer rejection, and as I said a moment ago, association with antisocial peers is the most powerful direct predictor of delinquent behavior. So again, as we heard about this morning, putting delinquent, substance abusing kids together in groups, what would we expect from that? They find new contacts, new sources, and what's that?
They make friends.
They make friends with the kids we don't want them to make friends with. And they're spending time in activities with antisocial peers that they could be spending instead in prosocial activities, building their prosocial network. At the school level, research points to academic difficulties, low grades having been retained, behavioral problems at school, negative attitude towards school, and attending a school that does not flex to youth needs. And at the community level, risk factors include availability of weapons and drugs, high environmental and psychosocial stress or violence, and neighborhood transients, neighbors moving in and out. Finally, at the youth level, risk factors include ADHD and impulsivity, positive attitude toward delinquency and substance use, lack of guilt for transgressions, and negative affect. So none of those are surprises, right? But looking at that level of specificity from the research can help you think about whatever the parameters or focus of your program, how can you draw from the research to determine which elements to target that are going to be most relevant for your youth? Yes?
Is there any research on delinquent peer groups doing something together in a pro-social activity, like a supervised pro-social activity?
Yeah, the research is very compelling that all the best efforts of even really strong, skilled group facilitators, therapists, leaders cannot compete with the sheer frequency and potency of the peers' impact. So they did micro-level coding, one of the seminal studies by Deshawn out of the Oregon Social Learning Center. They did micro-level coding, and just the number of times that the negative peers reinforced negative behavior so hugely outweighed the appropriate reinforcement of the leader that they have hypothesized that that's one of the reasons grouping negative kids together, regardless of the activity or the skill of the leader, the risk of doing harm is so high. If you have an alternative, why not pursue an alternative? Any other questions or comments? So if we think back to the, did you have a question? No. If we think back to the concentric circles that we saw earlier, the social ecological model, building on this research and building on that theory, the most impactful interventions are going to be behavioral, skill-based, maybe cognitively based, but primarily through the caregivers, through the teachers, through the people that are with that child day in, day out. I was thinking about this during the plenary, hearing about the dosage effect. Think of the dosage effect that a youth receives when they're getting this kind of reinforcement for positive behavior, sanctions for negative behavior, positive interactions. How many hours a day can they get that from their parent, from their coach, from their teacher? If we're working to help the people in the youth system to develop the skills to teach the youth, what we want every child to be learning, right? Day in, day out, a developmentally normal trajectory, kids are learning these skills from the adults in their environment. So if we help the adults in their environment be more skillful in how they manage and teach the youth, how many hours of intervention can we deliver to that youth through those adults in their lives versus a treatment provider who may be able to meet with them 1, even 5, 6 hours a week compared to, 40, 30 hours a week, 100 hours a week if we add up all the hours that those adults spend with the youth. Next area to consider incorporating into your program is to attend to and build a strong stakeholder and community context for your program. The literature across various domains consistently cites the importance of stakeholder involvement and buy-in throughout all stages of the implementation process of a program. And this information comes from the National Implementation Research Network, which focuses on implementation of evidence-based practices. in this context, it will help you guys to develop a picture, an understanding of the local big picture context in which your program is operating. You may already have that picture pretty well if you've been in your community for a long time. Develop an understanding of the current status of efforts being made with delinquent youth. Delineate how your innovation can contribute to the larger agenda. Look for where your objectives are overlapping. And then articulate cost-effective strategies, especially in these times. Mobilize the interest and support of the key stakeholders in your community. Those who fund, who could sustain your program post the funding you're getting now, are a good one to target. Identify champions who are committed to the innovation. Plan and implement strategies to obtain support of key policymakers in your system. And then clarify how feasible is it to pursue the path that you're looking to pursue and how necessary change can be accomplished. Last category is QA and CQI processes. I'm not even going to try to define the distinction between those two terms, which if you go into the technical literature gets very easy, but it's just all about continuous quality improvement. And Len Bickman is somebody in the mental health world who has done a fair amount of research in this domain and writing in this domain. And from him, we know that in order for mental health practitioners to learn from their experiences, they need to know the outcome of what they're doing, right? They have to know if it's working or not, receive timely, correct feedback immediately on their work, know what they're doing, define, have a clear definition of the treatment strategies they're using and which ones worked and didn't, and then have the ability to apply this knowledge to individualize their treatment, then generalize the knowledge. In order to help clinicians do that, the kinds of processes you can develop in your project include defining and communicating standards. How is this intervention, how is this program going to be delivered? Provide training and ongoing support, because people don't usually automatically go out and do what they've been trained to do after a single training, which from one of the directors of NERN, Karen Blasey, calls the spray and pray method. Gather information, monitor implementation to find out what actually is going on. Compare the information gathered to the standards or benchmarks. For example, if there's a treatment fidelity measure, use that to assess how well the treatment is being implemented. Then use that information to improve implementation and keep going round and round and round that circle. Assess, improve, assess, improve. So those are the three major elements. Build in research-proven focus and strategies. Engage your stakeholders and engage in continuous quality improvement activities.
And I would just want to say really to all of you that it's truly a privilege to get to be around people that are working so hard to help the youth of our day grow into the contributing adults of tomorrow. It is really, truly hard work that you do day in and day out, and it's just really a privilege to get to spend a little bit of time with you today. My name is Susan Sizik. I have a master's degree in education. My background, I have certifications in rehab counseling and psychosocial rehab counseling. So I don't speak like a clinician, even though I work in the behavioral health end of the field. I have a lot of psychologists, wonderfully skilled psychologists, licensed clinical social workers, and psychiatrists on my staff with whom I interact day in and day out. And they speak their language really beautifully, and I speak mine. So, you know, I'm here for the behavioral health workshop, but I'm not going to speak in a clinical kind of voice. It's just not who I am. Most of my experience has been out in the field. I spent most of my life working in child welfare, public health, and then programs in the community in the community. And then really most of my life working with people who had disabilities, primarily mental illness, substance abuse. Most of my clients were the uncooperative ones, you know them. So my clients were under the bridges. And those were the kind of people I worked with for very many years until I decided I really wanted to do some more family work and came to the Delaware Children's Department about 9 years ago. I love where I work, and I love what we do, and we have a lot more to do. So we're not perfect, but I really do love where we are. Delaware is a really small state. That doesn't mean we're not incredibly political. We're just small. We're just up the road a little bit. The population is naturally very fiscally conservative. We have one of the highest rates in the country of children that get expelled from daycare for inappropriate behaviors. We have high suspension rate, low high school graduation rate, and we are always in the top 10 of number of kids that are locked up. So those are some things that I'm not particularly proud of. Right now, we are in the midst of a pretty extensive budget process, as all of you are. We think our department is coming through relatively unscathed, and we're going to be able to keep everything in place and plus actually open up a few new things, which is very exciting. In Delaware, the state is the largest employer. We're a small state. All the government units are really centered there. So city and county government doesn't really do much in the area of services. We do corrections, public health, kids services, all those kinds of things. Except for education, we have 19 school districts in a state of less than 1 million people. So that does make some things a little bit more challenging to us. We are one of, and something for you to think about in your own jurisdiction, we're one of the dozen or so states in the country that have a combined children's department, which means that all of our child welfare and child protection services, all of our youth rehabilitation services, and all of our behavioral health services are in one department. What I love about this is that these are all of our kids. So nobody gets to say they belong there, or that's really a family problem, or whatever those things are that we all say to one another. We don't get to do that. And we are on strategic planning committees with one another. We go through requests for proposals together. We pick providers together. We do not work with providers who won't accept our children. And we train each other. You know, we learn each other's mandates, we learn what's similar, and we learn what's distinct among the different focuses that we have. And it has really helped us to build a better system for kids. Our employee satisfaction surveys on an annual basis indicate that we're doing a better job crossing through any of those barriers and breaking down those silos. So that's the system in which I work. Now, until last July, despite that connectedness, my division was called Child Mental Health. So we did mental health and substance abuse treatment. Prevention and early intervention were housed elsewhere, which really made no sense, because if you do good, just as Lisa was saying, if you do good work with the individual child, you're doing good work with the family and the other siblings. And if you're doing that kind of work, you are doing prevention and early intervention work. So in July of this past year, we became one division of prevention and behavioral health services. And I've got the mission and the vision of what we are now. So I live in the community in which I work. I live in the city of Wilmington, which is our biggest city, and I live in a zip code that is one of the 2 hot spots for juvenile crime in my city. Okay, so I've raised my children in this neighborhood. I know the people there. I'm involved in my civic association, which is part of what helps me, I think, frankly, be rooted to helping the kids, but also understanding the rest of the system's issues about our kids. I have a very strong belief in public safety, and I am absolutely sure, with every fiber of my body, that the more we lock these kids up, for the longer that we do it, even the fact that we do it at all, frankly, is not going to work, that a correctional approach does not work, and we have to really move from corrections to treatment. I think we're all trying to do that. Certainly all of you are. But I think it goes really deeply into looking at how we see the kids and then how we model that vision. And that means really looking at treating our kids as kids. Most of the behavioral health treatments for substance abuse or mental health really started as they were adapted from adult models, just like the correctional models. And there are now some really good evidence-based practices, as Lisa was saying, but many people don't know about those practices, and many people are still using the old approaches and still see the kids as little adults. And you all have probably been well aware of the brain research that has made we've got markedly better brain research that indicates how long it takes for executive functioning to come into place, for healthy decisions to be able to be made by somebody, and how unlikely or unreasonable it is for us to expect somebody who is 12 to be able to handle those kind of situations. So part of what we do in our state is we don't call our kids juveniles. We don't use the word juvenile justice system. We don't call them anything that might think of the word delinquent. We're trying to model children's behavior. We call them teens, we call them adolescents, and we call them children, or youth. Sometimes we'll say youth, but that's it. And we do that on a consistent basis because those are the words that inspire hope and that inspire all your stakeholders, all your people to be willing to invest time, effort, and money into these little guys, these little youngsters that are going to grow up and run our world someday. I think consistent with the system of care philosophy, we focus as much as we possibly can on the entire family because home is where our adolescents return. We try to keep them with us as short a period of time as we can. If they're in one of my residential treatment centers, we try to keep that period of time under 6 months. If they're a crisis bed, we're looking for 3 to 5 days. If they're in the hospital, I'm looking at 6 or 7 days. So I'm moving them home. And the longer they are away from home, the happier in some instances the family becomes. The family realigns, readjusts, it's a lot more peaceful, and we have a harder time getting that child home. So it is really hard work, but from the moment we think about discharge from the moment we meet the kid, and we work with the family over and over and over again. And I think the last piece, similar to what Lisa was saying, is that we really need to make the welfare of our children a community responsibility. It is not the responsibility of a juvenile justice system or a behavioral health system. It really is our community's responsibility. So some of the things that we try to do in our state is use all the months that come along throughout the year. April is Child Abuse Prevention Month, and there's always stuff that goes on in the press. May is Mental Health and Foster Care Month. September is Recovery Month, and school starts. And we do everything that we can to try to include our children in those kind of public service announcements, those press releases, the things that get in the paper. We do pretty well at that. And that doesn't cost us anything. In most circumstances, behavioral health treatment is voluntary. And even if it's involuntary, the actual participation of a child and a family in that treatment is voluntary. It requires a great deal of skill to assure that that interaction occurs. And that's why the training and mental health focus of professionals is so focused on building rapport, engagement, on establishing relationships. Dealing with behavioral health issues is difficult. Oftentimes it gets harder before it gets easier, and that's when our kids drop out. One of the ways we do this is by supporting the SAMHSA system of care philosophy and helping the teen and his or her family lead their treatment. And we don't always call it treatment. We have families that don't want to hear words like therapy. They don't want to hear words, the treatment doesn't sound good. Sometimes counseling is too threatening a word. So we work within the priorities and the culture of the people with whom we are working with to try to figure out what are the words that are going to help them get the kinds of support that they will accept and that they will continue to follow through on. It takes a great deal of skill on the part of a treatment professional to do that. One of the system building activities that helped us was that we were a Casey Juvenile Detention Alternative Initiative state. And that helped all the court, the legal system, and the treatment people come together in rooms and start to think about how we could keep kids out of detention, off the streets, and into positive activities. And what we did was after our JDAI funds were gone or used up, we really felt good about the progress we'd made. We had reduced length of stay in detention. We'd made some other very good system changes, and so we kept it going. And we have a meeting once a month that is co-chaired by the head of my department and the head of the family court, and all the people that have the power to make decisions come to that table. You kind of dare not, because decisions will be made that will impact you, and you're going to have to implement if you're not at the table. You can all do that. It takes leadership, it takes time, and it hasn't taken us any money. As a result of that, we're now looking at the civil citation program and the assessment center approach that is down in Miami-Dade County. Some of you may have heard about that program. That all came out of this group of people. Some of us knew about that program, but it really had to come through this group, and we're probably moving forward to take a bunch of our criminal things that we designate as crimes and move them into civil citation and move them back, the kids, into treatment quicker. So we're pretty excited about that. I think one of Delaware's innovations that has really worked for us, and you can do it whether or not you're in a combined children's department, is that we integrated our behavioral health services and our behavioral health staff into our juvenile justice or youth rehab facilities. So my staff is responsible for assuring that while the child is in our school for felons, our juvenile detention centers, our halfway houses, or any of other facilities, I have licensed people who are responsible for screening, for assessment, for psychiatry, medication, for treatment, for connection with families. All of that happens in the institution with my people. So I've got two systems on any given day that are responsible for that child. We keep QA on these kids. We know what services they're getting. We know if they're getting better. We know if they recidivate. We know where they've recidivated, what they did, and what we're doing to tend to that. And we report together. I mean, it's really both of our responsibilities. We had a lot of work to do in that. In my state, although we've worked really hard to try to have diverse professionals at all levels, the truth of the matter is most of the kids that are in our facilities are African American. Most of the line staff in our facilities are African American. Most of the treatment professionals are Caucasian. So we had work to do. I had to have very honest conversations with one another about what respect meant, what being a professional meant, what responsibility meant, and how we could work this out for the kids. And it's going really, really well. We've done some things on my system. I pay, if a kid is out in the community, gets picked up by the police, goes back to detention, I pay the therapist to go in and see the kid so that connection is made. If a child is in one of my services out in the community, something happens, they get picked up by the police, I keep that slot open for them for 90 days. Sometimes longer, if the slot is working, and so that I can bring them back and put them right into a service that they and their families seem to like, and move forward in that way. We have life skills programs at Boys and Girls Clubs, at community centers, at police athletic leagues, at all sorts of local organizations where we know some of our highest risk kids are likely to go. And so they're getting some form of prevention and early intervention, and sometimes a little bit of treatment thrown in there, but they don't really know it. And that's fine, because it seems to work, and it helps us out a lot. We also provide something called Promoting Safe and Stable Families. This is a really good program that helps vulnerable families frankly figure out what are their challenges and work them through. We offer that at daycare centers, and including all the ones that in our state are called purchase of care. Those would be the ones that serve a lot of families that are low income. We go to Head Start, so we're even going to family daycare to try to do everything that we can to strengthen the families who come there and to strengthen the daycare providers so that they'll be able to keep their child in the daycare setting. One of our most successful interventions has been something called Child Development Community Policing. Do any of you know about that? Okay. It came out of Yale. Yale and New Haven is about the size of Wilmington, our major city. And it is something that you have to have your police force interested in. But the police provide me with space in the police station for social workers. Social workers go out on any crisis that the police have identified. We do ride-alongs with the police, and if there is a violent crime committed in a neighborhood, we go door to door. Door to door for, like, in our community, the police decided it would be a 2-block contiguous area. And we knock on the door, we ask if there's any kids who live there, we ask if there's any help you might need with your children, and we find a ton of opportunities to help people. Shockingly for us, we never thought it would go this well. A third of those families are ending up in some kind of counseling. I mean, people that we never would have met, or I'd have met them after the child committed a crime. Most of the time we find families who are saying, my kid won't go to school, they've been disciplined too much, suspended too much. Because we work hard with the schools, we'll then work with that and try to do whatever we can to get that child back connected. So that's a really nice opportunity, and if the Yale Child Study Center has lots of information, and it might be something that you could do. Okay, school-based services. Lisa talked to you about how important school is. Our department has a vocational specialist and an educational specialist that are supposed to help our kids get back into school or get onto vocational training or a job, and they do a bang-up job. But we still have problems in schools. Our kids just don't do so well in those environments. So one of the things that we did was we increased the payment rate for any of our providers if they'll go to the school. So I give them $20 more per hour that they go to the school rather than have the kid come to them. Again, it sounds like, it sounds like a lot, but it's really, frankly, a very little bit of money. It really, really makes a huge difference to me if I can keep that child in school as opposed to having them thrown out and end up in a residential treatment center for God knows how long. Yes?
Does it help maintain their placement in school?
Yes. Yes. Yeah, we have really good data on that. What has happened is we see the child in their natural environment, we get to know their peers, we get to know the nurse, the teachers, and what happens is we end up providing some other consultation for the teachers in the school on other kids that might not necessarily be ours, but that's wonderful. So it's worth every penny to me. And we also pay our providers more if they go to the child's home for the same reason. So if my Medicaid rate is $20 more per hour if the therapist goes out of the office someplace. We've been very fortunate because in our state, the Metropolitan Wilmington Urban League has been also concerned about differential discipline for children of color, and that has helped us, frankly, because we are on the same page as the Urban League about allowing children to be in school. And that has been one of the partnerships that has really helped us and frankly took it to a whole different level of politics that I didn't have to be involved in, but really then we could come in as a solution. Beginning discharge at admission, that's all about knowing the family, learning the family, and getting them ready to take the child home. I told you about screening and assessment. I'm a little concerned about time. We have family nights that at all of our institutions, and those have worked pretty well. And how we've made them work, besides what you usually do, food, babysitting, we've brought in community services that are beyond the adolescent that we're treating. So we have things like, for the family, information on what do you do with your 8-year-old, how does your unemployed spouse get a job, those kinds of other things where that might be helpful to you as a family, so that if you really would like to ignore this child that's with us and not have a relationship with them, we're going to try to catch you with some other things that you might be interested in. And then continuity of treatment. I talked to you about how we will let therapists in and out. My staff is part of the team that helps assure that the child leaving any of our institutions gets to the right treatment. And that again has really, really been helpful to us. Okay, the community conversation is really about That was about keeping them in the community. And I told you that we have work to do on that because we still are a high lock-em-up state. So that is a problem for us. But we had some of the community issues, the conversation that had to go on was within my system. And it kind of went like this, and you've all heard it. You know, they're not ours. They're bad kids. They belong in youth rehab. They don't have a mental health issue. They don't really have a substance abuse problem. They belong someplace else. And that had to go on in my system. And how I cracked that was I just kept on feeding back the information. And basically, the diagnoses that, even if you took out anybody who was in youth rehab, the diagnoses we treat the most in my system are ADHD and oppositional defiant disorder. The diagnoses you see the most, as Lisa was saying, within juvenile justice kids are ADHD, and oppositional defiant disorder is the definition of the behavior that oftentimes ends up with children in a juvenile justice facility. So that's what we kept on feeding back. This is what it says in the DSM. You can't say we don't serve these kids. And look at our numbers and look at where they are. So let's make sure that our programs are able to treat and effectively serve the kids that are going to come to us one way or another. And so we focused on that. And as we were focusing on improving the clinical intervention and the family engagement, my partners in youth rehab were focusing on reducing detention length of stay, reducing some of the charges, looking on non-secure detention, case management. The department started to focus on academics and vocational, and we just started down this little road. We could not have moved forward without the support of family court. We still have challenges with family court, but they've done a really nice job. We have a drug court, adjudicated drug court, and a diversionary mental health court. And what's good about them is that the officials that work in those systems really get to know us and trust us and are willing to try treatment. And that has been a really good conversation. We are a state that has one of those designations of having not enough mental health professionals. So we have a federal designation. We don't have enough people to serve our population. We don't have a medical school in our state, which might be the reason, but you know, who knows. Whether or not our state that is blessed with that descriptor, you're not going to find a ton of people who are coming into the field and who want to work with our kids. There are not a ton of them. So therefore, I looked at the ones that come in, they're precious. They're my commodity, because I think that the best gift I can give a child is a treatment professional who wants to work with them and knows how to work with them and is going to be able to bring about the outcomes. So in addition to investing in my providers being mobile, I invest a lot of money in training, and I do all this for free. I bring in evidence-based training. We work together with, again, with our partners in youth rehab. We're doing the CASOM training for sex offender management, trying to, wrap up, I gotta go. Okay, we do the training in the game. All this is stuff that we do. We do CE events twice a year, and then we hire professionals to consult with the people with whom we work throughout the year so that they can talk about individual cases and learn how to be skilled. It takes a big part of my budget, but it's really, really important to me. Okay, these are other things that we do. Lisa said work on the schools. I spent the money to support PBS in schools. That's positive behavior support. It's a school environment program. One would think education should fund it. I needed it. I am paying for collaborative problem solving, and that's a teacher intervention that is to help teachers deal with kids that have disruptive behavior, and that's because I don't want the school to throw them out, and I don't want the teacher to throw them out. And then I am now piloting a trauma and grief component therapy for adolescents. It's a trauma group. I'm piloting it in 3 middle schools right now. The schools really like it. The kids aren't getting suspended. So, and they did a really good job. That's the other thing. The schools identified for us their troublesome kids. 100% of the kids that they identified going through the UCLA and other screening instruments had PTSD. So they knew who was a mess and needed help. And then we've been trying to do some work with them. PCIT and CARES are young people interventions that are other things that you could find online. That's our website. The second one is a website that we developed for school districts and for professionals to help in the school system to help them know about what's available. And the third is the National Child Traumatic Stress Network. It's a component of SAMHSA that we have found to be extremely helpful for us. They have some great CE programs for professionals.
Quick piece just on behalf of our Administrator Hyde from SAMHSA, our Center Director, Dr. Clark. Greetings from the federal government. And my piece of this is, sorry, I just couldn't resist. My piece of this is really going to be to sort of give you a little overview about what we found in effective adolescent treatment over the last decade or so. And really, I just have to just start this whole thing with, I stand on the shoulders of giants. A couple of years ago, 1999 was the first conversation I had, and one of the beliefs I've always had around adolescent care is right child, right service, right time. We often don't do that. What tends to drive the system oftentimes is people catch them as they can. And it's not a very methodical approach always, so they fall into a lot of places, either out of our schools, into other things that we may not hope for them. I think we can do better, and I think over the last decade we've been able to show, when we look at developmentally appropriate care, that I think we finally got there. I'm gonna, just a point of clarification, I just put this up as a snapshot. Some of the things I'm going to show you some nice little pictures, but we're going to only pick a couple of things out of. When we look at the history of adolescent treatment and research related to it, it's really not necessarily been a lot and very robust. So I'm not going to go through each of these, but what I suffice it to say, when we go through and look at over what's happened in the last decade, prior to 2000 we had about 14 published studies on adolescent treatment. Since that time we're pushing towards nearly 400 published studies. This is very big. We literally have the largest data set we've had from SAMHSA on adolescent-specific treatment historically right now, which is pretty interesting, actually. Some of the stuff I'm going to skip over, but I do want to get a couple of points here. Prior to '97, we really had lack of standardized and evidence-based assessments. Again, what drives the care that a person gets is the quality of, I hate to say it quite like this, but it's the sort. What is it that you need? Right child, right service, right time. Are we adding a very big service that may be overkill, or are we doing some smaller interventions or some smaller things ahead of time? And we haven't always had that thinking. When I arrived in Washington State, which is where I hail from before I came to SAMHSA, the only thing that we oftentimes would talk about is adolescent care was inpatient treatment solely. Now that's probably fine if you need inpatient, but it's not always required. So again, we're trying to stratify the system. Participation, treatment, completion, and follow-up rates were often very low. It's hard to have any validity if the follow-up rates are pretty low in that capacity. So, you know, those things have all improved. More importantly, we go talk to people, and they go, well, this is what I do. And we're going, okay, so tell me about that. How do we do that? Well, we don't really have a manual. Okay, that's a little problematic. So, so those things have really changed, and I'll talk a little bit more about that a little bit later. Difficult for clinicians, evaluators, and researchers sometimes to work together. Depending on how it was structured in your state or other states, when you look across the spectrum of the U.S., again, it was kind of catch as one can. So we had a lot of challenges to overcome. And I would just say in the last decade, 14 years really, I think it's been vertical, just in terms of what we're seeing on all fronts. And that is very pleasing. Here's just a snapshot of that. Again, I am not going to read through all of these. But this is where we started from a SAMHSA perspective in adolescent treatment, and kind of where we've worked today. Where we're at today is continuing partnerships with OJJDP, U.S. Department of Education. All of those folks have been very grateful and willing partners to really think differently and outside of the box. I always hate to use that word, but so, all right, so big changes. So 80% participation in some of our evidence-based use, in the use of evidence-based assessment. very different from where we started in the earlier years. We've got pooled data now, and actually this number, I need to change it. Actually, we're about 22,000 in our pooled data sets now that are all of our grantees. How we got to the number of publications is a very simple one. De-identified the data, so now they can go through their various IRBs or use that data to sort of take, I call it my Johnny and Ginny hotshot. If you think you've got a great idea and you want to do the protocol, then let's just measure that. And that gives them an opportunity. So we've seen a lot of people publish in recent years that probably wouldn't have published prior to, and sort of move forward in that, which has been very good, I think, for the field. We supported the creation and evaluation of over 20 adolescent treatment manuals to date. And so that sort of moves us forward here. Again, we don't promote or endorse any one treatment. What we want to do is give you a range of things. So here's some of the things that we've done. Motivational enhancement therapy, cognitive behavioral therapy, MET-CBT5. For my educators, I actually had to rename that. I served as the principal investigator on the Olympia EAT site, and we just called it brief intervention because my schools could never get beyond MET-CBT5. The adolescent community reinforcement approach, 74 sites on the AFT program to date, multiple independent grants in a number of ways. FSN, motivational interviewing, MDFT, multisystemic therapy, 7 challenges. Here is just a quick spectrum and snapshot of what that looks like across the state. We've got a couple of really good grant writers in some locations. You can see really, there are a few states that have golden pens. so it's always interesting for me when we go across this particular one. All right, so let me get into the meat of the matter, really. So what does it look like when we look at that 19,000 set of records? So 15 to 17-year-olds, who's getting there, about 26%. You can see sort of the ethnicity breakup there, single parent, those kinds of things. Interestingly, though, 12 to 14-year-olds at 18%. It's a little higher than I think some people might have thought. The CSAT data is diverse with large numbers of females and minorities. You got to remember, this is of 19,000 records, so 18% of 19,000 is a fairly substantive amount. Who are those youth that are involved in the systems, placing competing demands on them and potentially in conflict with each other? I just want to appreciate both of my colleagues going prior to, because I think what most of us will start to see is more and more movement and integration. And to the gentleman who was wondering how you pay for some of those things, it starts to come down to economies of scale. When you look across the systems, certainly was the way in my previous state where we had sort of duplication at various points. Sometimes kids would go through 2 or 3 assessments. I can't imagine what that must feel like as a child. That those things aren't particularly helpful depending on what that goes. And so that's, we're all going to be pushed more and more towards efficiency and integration. I suspect that'll take a lot of very robust conversation. So, interestingly enough, so we got 68% in the juvenile justice system, about 73% in schools. I happen to come from a background where we did school-based treatment. I tend to support and promote that particular idea only because that's where the kids are. So one of the things that I think really is going to become important here, so we've talked a lot about co-occurring. Multiple clinical problems are the norm. It's not, you get the child that crosses the threshold, not necessarily the one you want. And I know that's sometimes difficult for folks, but they come with everything they come with. And sometimes we don't always account for that. What is interesting is if you look at victimization at about 63% and trauma at about 24%, you can sort of pare that down a little bit. You can start to see why we're seeing some new initiatives around co-occurring trauma and justice, those kinds of things coming out of SAMHSA. All right, number of clinical problems by severity and by level of care. Again, outpatient, intensive outpatient, outpatient continuing care depending on your state and how that sort of gets sliced that way. Long-term residential and short-term residential. So if you just look at conditions, the red bar is 5 or more. So you can just see, just by looking at the picture, it's like, whoa, much bigger than I think sometimes we always give credence for. Major clinical problems, highly related to victimization. Again, low, moderate, or high. You can see the conditions as they flow. The red bar just sort of screams at you slightly. Again, significantly 5 or more problems identified. You can see where that sort of sits there. One of the interesting things that happens is sometimes in HIV we tend to say, oh, well, it's centered around needle sharing, those kinds of things. With adolescents in particular, that's really not the case at all. In fact, I remember sitting in front of a large group of superintendents and presenting data when we first rolled some of this out, and some of my superintendents were particularly concerned with the idea of us collecting any sexual practice behavior data from their children. When we presented the data, and Dr. Sue Haskins, who I love and adore, who literally screamed out and went, oh my God, when we had a preponderance of multiple sexual partners with a lot of our middle schoolers. And so a lot of things come on, but if you're not collecting the data and you're not doing that, you really don't know. It's a kind of a sensitive question to be asking, so well-trained, and a lot of the things that were said earlier is very important. All right, so let me move us forward into a couple of things that I think become related to some of the earlier conversation. So what we started doing is looking at return on investment. What are things that are portable, practical, can be done in some cases by paras, in other cases where you need really a richer body of experience and capability? So screening and brief intervention. So these are 1 to 2 days. MET-CBT5 falls in that category for me, although it's 5 sessions. Our cost is about $407. Now, I'll tell you, when we went head-to-head with the Cannabis Youth Treatment Studies, which is one of the first studies we did, it was the throwaway. It's the one that nobody thought was going to make significant change. It actually had quite a bit of change. Now, again, right child, right service, right time. If they're coming with quite a few clinical problems, that may not be the right solution. So I just want to give that cautionary tale, because sometimes people want to go, well, that's cheap, we can do that everywhere, let's just do that. Not always so.
I'm sorry, but it looks like this is kind of mixing your metaphors here, because methadone maintenance, therapeutic community treatment, drug court, those appear to be adult-based, not adolescent. I mean, how many?
Well, we're just using cost of treatment.
Oh, it doesn't matter.
Doesn't matter. We're just using standardized, known, evidence-based treatments out there. There are some therapeutic communities with adolescents, very few. Methadone maintenance, almost none. Residential treatment, but when you look, our juvenile drug court, when you look at these, this information by and large comes from Mike French. And so I don't know if you're aware of his work, but if you don't, I'd be happy to get you information. But he's probably one of the best known health economists around this particular area. So, but the point of this is when you're looking at your costs, that starts to make a difference in terms of what you're doing. So let's compare that to what it's going to cost you to incarcerate, put a child in a year of foster care, or keep a child in a year of detention. No matter any of these that you choose, it's still less than nearly all of that. So the return on investment is really what we're trying to support here, is that it's cheaper to treat than go the other route. Now, in some cases, that's not always a plausible situation. So just depending on your situation, there's not a one-size-fits-all. But again, you can add some other things in there. Single night in detox at $750, 1,000 night, $1,100 in a hospital. I won't go through all of these, but when you get down to the assault side of that equation, the costs continue to escalate. So that's the point of the whole conversation there. Investing in treatment has had a positive return on investment. We've taken pains. It's estimates of drug treatment courts. You can see all that information. I won't go through that. But on average, between $1.28 and $7.26 per dollar is invested. Seems to be a pretty inexpensive investment with a high yield. But every time we cut a dollar, which I think some of you are probably having some of those conversations in your various states, you can see where you're going to run into some other snags. So in spite of having the difficult conversations of how to come together, I think in the end they'll probably bear better fruit. Okay. So let me try to move us forward here just a little bit. We've got about 5 minutes, and I want to get to at least a couple of questions. One of the things that I think is important out of the 509 juvenile justice studies, so Mark Lipsey did a study here recently, so average practice, most having about one feature. The more features, the lower the recidivism. I know it's kind of intuitive when you just think about it. The problem is that that's not always the case. And therein lies the problem when we move forward. So when we looked at evidence-based practices that typically do better than sort of treatment as usual, this was our list. Again, we don't support or endorse any one of those, All of them had great outcomes at great cost, and that's the key message that we want to suggest for folks. Small or no differences in mean or effect size between the brand names is kind of how we view that. So again, here's all of the rest of those. Let me move this forward here. Other common findings: low structure and ad hoc treatment as usual does not really do very well in the scope of it. And the support around sort of the quality assurance. I know it's painful, but it really is kind of a requirement when you think about it. Small things do in fact make big differences. So a couple of things. Wilderness programs in particular had quite mixed effects, treating adolescents like adults, and I just want to underscore developmentally appropriate treatment. Adolescent treatment really kind of, for the most part, came out of adult treatment systems. It wasn't that long ago when we said, what could we actually do something for them? We've tended to do it that way. Relapse is still common, so there's ongoing need for support. So I call it tethering, but it's staying engaged, and that's the key as far as I'm concerned with adolescent care. All right, so I want to move beyond a couple of these things because we just simply will not have time to do any of that. But the one piece I do want to talk about is something that I heard earlier around implementation. Implementation, as it turns out, is as critical as anything else you're going to do. We don't often like to talk about it, and you know, in the best of all worlds, you could take any one of those programs and do it badly. And I'll go back to the reference to Thomas DeShawn. So in his article around When Interventions Harm, you know, you can do anything badly at the end of the day. And if you don't really focus and sort of get the priorities right, then what tends to happen is you get not such good outcomes. But even if you just implemented an evidence-based practice moderately, it's still better oftentimes than treatment as usual. So while not ideal, and most of us would probably grimace a little bit around that notion, the best way to do it, of course, is, you know, implemented well. So when you do the best, so you have a strong program implemented well, all of a sudden you're getting much more effectiveness. Which, when you're starting to count up your dollars and your nickels, dollars, and dimes at the end of the day, I'm going to think most legislative bodies right now, or those who are holding the purse strings, are probably looking at you with that eye of, what kind of return on investment are we getting? Thus, one optimally should pick the strongest intervention that one can do well. And I think that's the key. Depending on your type of organization, you may not have the qualified staff to do MST. You may only be able to do something different. So you have to find the intervention or the treatment that you can do well and spend a great deal of time moving forward with that. It would be a tragedy in my book to do something badly that way. So, all right. So here's the other pitch that I'll give you. Effects associated with coaching and certification. Typical, what I call sit and get training. You showed up for something. We might be an example of that today. So you showed up for something, you got it, a 4% effect rate versus a 24%. It matters. These small details matter, as painful as they may seem. And as an administrator, sometimes you may have a hard time in your mind justifying why you're spending additional money on either training, implementation, quality assurance, the extra care and time it may take to do some of that. But the investment is well worth it for the service, the delivery for the children. All right, so I'm not even going to go through any more of these other pieces, only because, well, other than to say, when we looked across all of the evidence-based practices, when we looked at mental health outcomes, the top 4 or 7 challenges, Chestnut Health Systems, Accurate ACC, which is the new version of that, and MST. All of them did great. And so, you know, as you're making your decisions and your choices, those are the kinds of things you'd want to look at. So, all of the programs reduced mental health and trauma problems. 4 did particularly well. Accurate ACCT programs with more training, quality assurance, and monitoring technical assistance did better than those with less. So I'll just kind of leave it at that. And then we're right on time. So if there's a couple of quick questions, if you need a copy of the presentation, want to see citations, happy to provide you with those if you'd like. So.